if I see that if I will be more eligible to do more grants and ventures with the VA appointments, then it will be great, you know. We're ready? Awesome. One light off.
Yes, sir.
Okay. Well, welcome. Hopefully there are more people that's going to trickle in as we start talking about it. How's everybody doing?
Yeah, very well.
Good. Well, today's topic is we go over Medicare benefits, what it covers, what it doesn't, what the patients have to go through when they try to join Medicare, and the do's and don'ts, especially during the transition time from the hospitals, and all the pitfalls and mistakes that we can make as physicians in terms of coding and billing and our assumptions about Medicare coverage. So objectives for today, the ABCDs of Medicare, and then towards the end we'll be going over some of the basic billing and coding things that we do as private attendings. And then we talk about towards the end what are the alternatives that we can be talking about and looking at to Medicare in case the whole top of the cards fall down. So what is Medicare? Who is eligible for Medicare? Medicare was started, does anybody know when it was started? Yeah. And interestingly, that's an age group that they targeted is in 1965, and the age that they're eligible for is 65 as well. Back then, life expectancy was probably around 60 plus, no much more than 70. So when you get Medicare and you're retired, more than likely you only have a few more years to live. The purpose of Medicare was for very aging, ill, disabled, retired persons. They need help with healthcare costs. That's what they were aiming for. And of course, everybody knows history. In the late 60s, 70s, managed care companies take it away and then bulldoze forward with Medicare policy that add on, and more stuff gets being added on to the Medicare services and the coverages. So there's many parts to Medicare now. It's not just Medicare Part D that was initially intended for. So as it was intended, is for people of the retirement age, 65 plus, or people younger than 65 with disabilities, or younger than 65 with end-stage renal disease that required dialysis. There's no income requirement to be eligible. It's administered by Center for Medicare and Medicaid Services, and then Social Security also get involved. They handle the enrollment part for A&D. In fiscal year 2010, there's close to 49 million Americans enrolled in Medicare, and the annual spending for them was close to $500 billion, $500 billion, and that comes up to the average about $10,000 per person. Of course, there's a skew in the consumption rate. I've been reading up online. The top 5% of the consumer probably consume about 50% of that budget. So the people who are the sickest in the top 5% consume a lot of healthcare dollars. And as a big chunk, there's like 50% of them that contribute to Medicare and hardly use like less than 1 or 2% of the Medicare spending. So for people with disability, then they collect Social Security. Then all of these are all the fine details that all the Medicaid and Medicare services will go through. So, and then renal disease is a big thing. So it doesn't have to have any other chronic diseases. If you have renal, end-stage renal disease, then you are automatically eligible for it. So there are exceptions for that clause that say you have to be on disability insurance for 24 months. And of course, those are the well-known stuff like ALS, which has a very poor prognosis, and their life expectancy is measured in months. lot of times it's people who are Medicare and then they're eligible for Medicaid because more than likely towards the end they get very impoverished, so or they need a placement into nursing homes and they have Medicaid and they're eligible for both of them. So, what do you think Medicare covers? The one that is the most well-known is what part, A or B? That most people know. Let me ask the newest member of the healthcare industry.
I'm gonna guess A.
A?
Yeah, I don't know.
What letters have you heard about the parts of the Medicare?
They don't teach us any of that, honestly.
Nothing?
Like active duty, no.
Not at all. Good. Well, we have a lot to learn today. So A, what do you think A covers?
Can I get some multiple choices?
Does it cover dialysis?
Yeah, I'm gonna guess yes.
Does it cover office visits?
Sure, yeah.
Unfortunately, no. Part A is designed to cover the more expensive stuff like
Okay.
hospitalizations, hospice services, and the skilled nursing care needed post-acute care right after you get hospitalized.
So no
That's-
preventive health care then.
So the Part B and Part A, we're going to go into that, what is covered, what's automatic, what's not, things like that. So Part A is hospital insurance. Part B is outpatient, the office visits, home health aides, home health services, home physical therapy and rehab services. Part C is relatively new compared to the other two, is Medicare Advantage plans. Medicare plan, there's a lot of them. So Medicare Advantages, it can be HMO, PPO, all kinds of stuff. Part D is one of the latest part. It came out after 2000. It covers prescriptions. I think we can thank George Bush for that. Here is an eye-dazzling array of what Medicare parts are. You don't have to go through them all right now because this is going to be the roadmap on what we're going to be talking about today. So A is premium free. If you want to get it early, then the optional premium is $426 if you're not automatically 65 and you want to buy it on top of like your group insurances. So that's what it says. Normally you only see Part A listed as a premium. Part B is, let's talk about Part B later. So the deductible per year for each eligible Medicare benefit period, which is probably, they consider that the 60 days surrounding the hospitalization. It's about $1,200. And then beyond the 60 days, if you're still in the hospital, then the deductible is $304 per day for that. So this is a lump sum for the first 60 days. That's what every Medicare A patients have to pay if they get hospitalized. All right. Part B is outpatient. You're not obligated to buy it. It is additional fees. Premium is about $104 per month. Deductible for the whole year is $147. The co-insurance that you need to pay, the physician fees, it covers 80%, so you have to pay 20%. And then there's an outpatient hospital cost, like outpatient ambulatory centers and all that, average about 20.7%. That's Part A and B. Part C is Medicare Advantage plans. You must have A and B before you are eligible to do this. And then there's Medicare Advantage with prescription or Medicare Advantage without prescription, Part D. And then under this umbrella, you have HMO, PPO. This is PFFS stands for private fee for service. Does anybody know what is fee for service? What does fee for service stand for? Alfred?
See the patient, you send them a bill for, what the service they had. So if they had a knee replacement and that costs, $2,000, then they get a bill for $2,000.
Okay. So fee for service, you're absolutely right, it's like a free market kind of thing. It's a close to free market as you I guess, is a comparison. So anytime you want to see a physician, you go and see him, and then the physician will charge Medicare by sending a bill, and depending on what the reimbursement rate for that year is, then he get paid for that. Most other insurances follow Medicare rates, more or less, with maybe additional bonuses because they're private insurance and can afford to pay for it. So that's what's fee for services. And then it's a lot more it gets more complicated when you talk about preferred provider systems or organizations, and then the HMO, which is a healthcare management organization. And those are very different. I have some experience in HMOs too. And then under those umbrella as well, there's special needs programs and then medical saving accounts. So there's a lot of things you need to cover. And the Part D is so this, I don't want to go into that until the very end after I explain the basic things, because you hardly see many of those, only in special situations that you see those things. And you would notice, because then your billing or coding or your referral person will always come to you, because they are the one that generates the most headaches, a lot of headaches. So Part D, as also similar to Part C, you need to have A and B first, and then there's a premium, and then there's a deductible, and then there's such a thing called a donut hole. It's on there, but for many years I didn't know what a donut hole was. Does anybody know what a donut hole is? Lady, do you know what donut hole is? Donut hole is what the patient are responsible to pay, because the Part D is designed in a way that for the initial coverage you get this much, and you have the deductibles and all of that applies to this. Approximately you are covered for 75%, so you pay 25% of this, $2,800. But after that, this is we're talking about prescription fees. We're not talking about office visit fees and all that. So, for example, if somebody has Cymbalta or Lyrica or Novolog or Levemir or anything like that, any of these expensive medications will quickly reach this probably in the first 3 months. Will reach that. So beyond that, there is catastrophic coverage. This is the annual cap. This is the cap, and between this amount and this amount is what we call a coverage cap or donut hole. And this is the latest amount. This is from the CMS website. It's pretty good for this year, $1,700. It used to be that they paid the catastrophic cap was $6,000 or so. Then the patient ended up paying $3,000 to $4,000 on prescriptions alone, and that's the dreaded donut hole. Everybody's complaining about it. The way to go around that is to prevent it from happening, which means that we use more generic medications and insulin that are off-label or off-branded, which will be like NPH or regular insulin. And it's better than having no insulin. So this is essentially what's happening. So now more details. What does Medicare A covers? It covers anything that's medically reasonable and necessary stuff, which means that for inpatient hospital care is covered with all the applicable premiums and deductibles. Psychiatric hospital care is covered. Skilled nursing facility for the first 20 days is free. You can go there after hospital. What you need, this is a key part. This is the most common pitfall that if the case manager in the hospital doesn't know about it or they don't want to, they forget to mention it to you. If they're not inpatient status for 3 days, then you have to keep them for 3 days. Otherwise, they're not eligible for that Medicare benefit.
So say at the inpatient status.
Not observation, yes. Physically in the hospital does not count towards that. So that's very important. So yes, it happens on ACE a lot. So somebody admits somebody overnight and with observation, nobody caught it until like second day. And then they want to send him to a nursing home and say, oh, great, we ought to change him to inpatient status. And then you have to do that, and that's like extra 1 or 2 days in order to meet that criteria. Home health care is covered. It's we need to keep, you know, filling out the forms for that to happen. And then hospice care is covered. And then this is a part that I didn't know that I found out is that even the blood that we use is charged to the patient, at least the first 3 units. So Part B only covered 80% of that. So that's important. Of course, if the blood is donated, then it's fine. Like a family member donated or you auto donated before surgery, then that doesn't count because of your own blood or something. And then Part A, the premium, $0. And then the people with disability need to be on it for 24 months. And deductible, as I mentioned, this is the latest amount, it's $1,200. And then there's always cost sharing and co-payments and co-insurance, as I mentioned, for the varying amounts of periods of the hospital stay. Part B, it covers most of the stuff that's outpatient, physician visits, diagnostic tests like chemistry labs, rehab services, DMEs, ambulance rides, mental health visits. There are a lot of limitations for that. And then outpatient physical and occupational therapy. So what the Medicare Part B does not cover? Routine dental care. I think it's covered under Medicaid, but not Medicare. Eye exam that is meant to use it for prescription glasses is not covered. We always say, oh, go to your eye doctor, they'll take care of it. That's another assumption that we make. It might not be covered, it is just for prescription glasses only. Routine hearing care, not covered. Routine foot care, not covered, but there are some exceptions like diabetes. Acupuncture is not covered. Cosmetic surgery, of course, it's not covered. Long-term care, this is a big thing, it's not covered. So if you put somebody in a nursing home for custodial care for chronic illnesses that cannot be reversed and they just need a safe place to be, it's not covered.
So the routine eye exams might cover for somebody with like a diabetic retinopathy.
Mm-hmm.
With glaucoma and things like that, yes. But
The worse the eye, the better they cover.
unfortunately.
I thought acupuncture with a diagnosis for like back pain, some of it might. I had patients getting acupuncture.
Those policies probably depends on what
The
supplemental.
supplemental insurance.
Blue Cross covers
Oh, it's
6 to
the-
10, I can't remember
Yes.
sessions per year,
So those
but
are supplemental.
I think it's their supplemental
Oh,
kicking in,
okay.
I don't think, as far as I know.
Medicare.
that-
Some managed care companies will pay for it if they have contracts with acupuncturists. But if they do, it's not gonna be with any acupuncturist, it has to be their acupuncturist, more than likely.
In my understanding for the hearing care, they can do the initial screening
Assessment.
tests, but they can't, they won't cover
For
anything for
hearing
any sort of
aid.
intervention.
So the premiums, this is a breakdown. This is from the 2010. There is, it's all income related, as opposed to Part A. So if you earn a lot of money, then there's always an additional cost that you have to pay for it. Full harmless provision is there to protect Medicare recipients who are very much reliant on Social Security benefits. So they don't have their own 401ks or any other income. It's supposed to protect them against rate hikes on Part B that applies to them because they're on fixed income, their Social Security checks levels goes up every year to account for the inflation. At the same time, it also protects them against unreasonable hikes in Part B premiums. There's a late enrollment penalty period. If you are eligible but that's not enrolled in Part B right away, you're okay and exempted if you are still employed and you're covered under a large employee health coverage. But otherwise, if you change your mind when you're eligible but you didn't sign up for it, it's 10% every 12 months.
And I think this is, I know the social worker at our clinic brings this up because she sees this not infrequently. You have 6 months, right, once you turn 65 to
Yeah.
enroll. And so we've had really unfortunate situations where patients just weren't aware of that. And once you miss that window of opportunity, it is really, really tough. So I had a couple of really sick patients who, you know, University Hospital, hundreds of thousands of dollars because they missed, or UHS health system, because you get A, but if you don't sign up for B, like you can't ever go back and undo that. Anyway, it's just, I never knew it was such an irrevocable kind of decision, but apparently it really is. So if you're taking care of people that are 64 and talking about Medicare, just tell them, you gotta like pony up right away.
Right.
Or your parents.
Or,
Unless
yeah.
you have no prescriptions, and you don't go to doctors ever, not because you're stubborn, but because you don't have any health issues. Then you might consider that, but even then it's just too risky. Too risky not to sign up for Part D as well, because everything hinges on that.
That affects the premium every month for the rest of your life, right?
Yes, it does. It does not, the penalty never
It's
goes
not a
away.
one-time penalty.
No, it's, the premium is until you die, essentially. So if you wait 2 years, that's 20%. And for people who are on fixed income, they can't afford that. So I guess there's a little saving grace. This penalty resets if somebody is on disability and they turn 65. So you don't have to use, I guess, Part B when you're on disability, and then they turn 65, then that magic number resets the penalty. So once again, this is an example of what we do. Most of the cost is 80% is approved, is covered. You pay 20%, and if you don't want to pay, then you need to get supplemental health care cover for that. So then there's the prescription Part D. It was started in 2003, became effective in 2006. It covers most prescription drugs, both brand names and generics. It covers all the expensive things like Humira and all the biological agents. And of course, all the vaccines are covered. Insulin gets covered too. There's a clause that says this, you need to cover at least 2 medications in each class, but there's exceptions like for psychiatric or antidepressants and things like that, then you have to be, most of them have to be more widely covered. So criteria for that medication to be covered is approved by FDA, sold and bought and used in the U.S., and only for medically accepted indication. Formulary,
That's a catch.
formulary is, what is the catch,
Medically
sorry?
accepted indication is the catch, because so many drugs are used off-label
Off-label.
Yes.
for really good things.
Mhm.
It's an uphill fight.
You got it. And every year, I believe, is always changing. So this is what I'm talking about. So the plan has to cover at least 2 drugs in each category or class of medications, like blood pressure medications. But the exceptions are antidepressants, antipsychotics, anticonvulsants, or antineuroplastics, immunosuppressants, and HIV treatments. Then they have to cover all of them, or substantially all of those drugs in that category. So that makes sense, because those are the more expensive medications and treatments. Any questions or comments so far? Own experiences? But as Denise was pointing out, yes, Part B thing can be quite life-changing if you didn't sign up for it right away. So that was a good catch. So what is not covered under Part D? Weight loss, regimen, medications, of course for cosmetic, Botox, those things, if they're for cosmetic purposes, cannot be covered. Over-the-counter stuff would not be covered. Vitamins would not be covered. And then there are exceptions and clauses for all the sedatives and fertility agents would not be covered. And then this is a big one that most people don't know, Cialis and Viagra and all that. More than right now, all the insurance companies are mulling after Medicare. They start not covering for any of those, unless you happen to be like Cialis and you can dually prescribe them for BPH and hopefully hope that they get covered.
Now, are those covered for somebody taking them for pulmonary hypertension?
That will be for different purposes.
So, but then it would be allowed?
Like Revatio, yeah.
Yeah.
Yeah, yes.
I mean, it's the same drug.
You still have to get,
Different.
usually, it seems like, at least 2 of my patients, you still have to get prior auth, like, depending on their.
A lot of hoops to jump through.
But, but they get it, because it's like 20 TID, I think. So it's a different dosing, whatever, but yeah.
So if someone has like appetite loss from cancer therapy and Megis and stuff, they don't cover them at all? It's
Well,
not just,
I think right down to it, if you come right down to it, most of the time those medications, you have to jump through extra hoops. So automatically they might reject it regardless of the indication, and then you have to call their doctor, depending on the health plan that you're on, and then you have to have a doc-to-doc talk. They say, okay, this is for this purpose. I know Medicare doesn't cover that, but we need you to pay for it. So this is after the Part D. We're going to go swiftly to Medicare Advantage plans. So most of the patients, this is their myth. If you have Part D, you don't have to pay for prescription drugs. Unfortunately, that's a fantasy. It doesn't really, I mean, most people who talk to each other, for somebody who has Medicare for a few years, they know what a donut hole is, or they will find out pretty quickly what it is. And then this is a Part B cost, same thing that we talked about. This is the different numbers for 2010. So I just wanted to show how much the difference was. The donut hole back 4 or 5 years ago was even bigger. So that was, because the catastrophic cap was much higher. So by the way, there are handouts that has all the details of that. So if you want to pass them out. Sorry, I didn't do that at the beginning. So, what are Medicare Advantage plans? They are covered under Part C. There are private companies that contract with Medicare to give the services to the recipients. By design, they have to have Part A and B involved in there. Some of them have Part D, some of them don't have it. So the Medicare Advantage plan is, joining them is optional. So the people that usually join them are normally people with a lot of chronic diseases with a lot of costs, because Medicare Advantage plans are supposed to reduce the cost of co-payments, but the caveat to them is that your freedom is lost. You have a lot of restrictions on, because for most of them there's a network. So you have to be within network. The company I used to work for is Humana. So with Humana, you got to have a network of people that they are only allowed to go through. And usually, if it is HMO, then the primary care have to do referrals to everything. So it's like a guy that is like a chief accountant that makes sure what's medically necessary and what's not. And he's a central hub with all the spokes going around the wheel that you refer them to. So it gets complicated that way, but it's supposed to make it simple. And they keep paying, this is an additional cost, so they keep paying for Part B premiums in addition to the Medicare Advantage plan premium. So, as I mentioned, so they have different supplementary stuff like the dental, vision, and all that, and also some of the acupuncture and other alternate medicine is covered. These are the different things. HMO, Health Maintenance Organization, referral provider organizations, all of that stuff there. So this is a big one. HMOs nowadays have different models. They have capitation payments. The model that I'm familiar with is capitation payments per patient per month. They get refunded because at full risk, what they do is, if you can prove that somebody has chronic illnesses, let's say cardiomyopathy, ischemic cardiomyopathy, whatever stage, history of cancer that's in partial remission, depending on that, the chronic illnesses and the risk that carries with that diagnosis, they have all automatic calculations on how much average monthly cost or over the whole general population of the United States is going to be. So for example, somebody with only hypertension and he's relatively healthy, they might pay you for capitation maybe $300–400 a month, and you multiply it by 12 months. It's a lot less than what the average Medicare recipients, if you calculate all that, we calculated it was 10,000. So they prorate it that way so that overall, that depending on how good a job you do, if you keep them healthy, if you keep them out of the emergency rooms and hospitals, then the companies that work through that model gets a lot of rewards. So financial rewards out there. Specialty programs are people, for the most part, it's for people who either live in institutions or people with dementia, diabetes, and CHF. So those are specific diagnosis codes that make you eligible for that. And that usually covers prescription courses. Yes, go ahead.
And I just, so here in San Antonio, I know like some of my patients would get cold called during the benefit enrollment period and actually enroll in a Medicare Advantage plan without being aware of it, and show up at my office with their insurance cards they got in the mail, which they thought was traditional Medicare. So some of them, and I keep wanting to call it Sunrise, but I don't think that's it. There was one that started with an S when I first moved here about 5 years ago that was particularly aggressive about that. And there were about 3 primary doctors in San Antonio who accepted that Advantage plan. And so the patients were really screwed for a year.
And then they get assigned on the card. They don't have any say in that sometimes.
And then there were virtually no subspecialists that accepted that. So I don't have the best feel about some of their practices, at least here in San Antonio. And a lot of patients don't understand. They think it's just another kind of Medicare. And they said I'm going to get vision and dental coverage, and so I went with it.
Yes.
But they don't understand that they're not going to be able to continue to see their cardiologist who's seen them for 15 years and continue a relationship with established physicians. So anyway, I just think if you are practicing in the community, it's important to know about them.
Yes.
And be able, because patients, as I, may not understand that distinction. And then as I say, you can't enroll again in traditional
For
Medicare
another
for a
year.
year.
Yes.
So they.
That's a very good point. Because the Medicare Advantage plans, their enrollment periods in November and December. And they get cold calls, phone calls all the time. And, most of the patients in that age group is demented, and with their judgment and the insight is not that good. So then they sign up for it, and then they get something in the mail. The other one that, not just the dental and vision, is Gold's Gym membership, silver slippers. That's a very, very lucrative.
Silver sneakers, yeah.
Yes. Not only that, but it's the free gym memberships. So they lure them with that, and all the elderly get bought into that. So it's really bad. So those are the common pitfalls that you're going to have to be watching out for. Because once that happens, you can't do anything about it. They can't even see you. You become at the mercy of the primary care that they get assigned to. So you're like a consult if you're seeing it. So before you see that patient who is on that plan, HMO plan, you need to call the HMO plan, get the primary care to approve them to see you that day. Otherwise, you can't even see them, or you can see them, but it's going to be free of charge. You cannot bill Medicare for that.
Alfred, say something about the difference between Medicare Advantage plans, HMO and PPO.
HMO and PPO. PPO is kind of still under the same umbrella, but PPO, you don't need to have a primary care, and you don't need referral to go to specialists. HMO, you need to have one assigned primary care doctor, and he's a guy like a quarterback that passed the ball. Because without him, the ball doesn't get passed. Nothing happens without him. No surgeries, no chemo, no CT scan, no MRI. Nothing gets done without him in the HMO. No psychiatrist, nothing. And by the way, Medicare Advantage plans, for the most part, is very, very weak in psychiatry. They do not, for the most part, pay for mental health. And that's where they get the most savings, for the most part. That part, I was not aware of that until recently, so. So these are all the different premiums. They can go from, go all the way up to $203. And we already talked about some of the deductible. And it's not free. Some of the plans, it's free to see the primary care, but it's not free to see specialists. So you still have to pay deductibles. But it's cheaper. They buy you out with, say, oh, deductible is not $25, $35, $10, or $15. So some of the choices that people had to make is why, delaying the Part B, whether or not they should join Part D, what's the difference between Medicare Advantage or Medicare policy. I've never actually personally seen somebody with Medicare, but maybe something like AARP or something. That's I didn't really have time to go into. And then if you have already Medicaid, they have to go for a SNP. So for Part B options, you can delay enrollment if you are already employed and they cover you, then you have an excuse for that. Other than that, in a large group plans, this is what the employers do. It's not that pertinent there. Enrollment periods are important, something that you need to know. Initial enrollment period is 7 months surrounding the month of eligibility, which is usually your birthday or birth month. General enrollments run from January to March. For Part B, there's a special enrollment period for somebody who was covered by their employer and then they get delayed. There's a special one for that. And then for that, during the special enrollment, it begins on the first day of the first month after the coverage got dropped, or when you got fired and then health plan coverage ends.
So the example here would be somebody who works until they're 70, and then retires. They
Yes,
have,
and they have a special window.
so if they have Blue Cross through their employer and they choose
Yes.
to keep Blue Cross.
Exactly. So then, if that happens, of course, there's no late penalty. Part D, there is also a late penalty for that, unless you are covered under the VA drug plan or the primary care drug plan. Then of course those are really credible and really good plans. So, and they have understanding between the different federal programs. And this is just to go through what the credible programs are. And then there's a lot of misunderstandings about, where there's like dozens of Part D plans. It's not always true that the higher the premium, the better coverage it is. So it really puts a lot of stress and responsibility on the elderly to really pick up that. It is a daunting task even for me to go through all the rules and regulations and different things. And if somebody's not computer savvy, there's no way they can, surf the web and find out what plan it is for. There's a lot of abuses going on because of that.
And there's not very many people who are savvy and are willing to do education and assist, which is what my mom's finding. And she's in that gap of, my best friend who also has Medicare tells me to use her plan. I was like, no!
You may take completely different
Don't listen
medicine.
to them. They're not smart.
So the best advice for me that you need to know enough to tell your patient is find out which plan has coverage for the medications that you're on, or maybe you're going through a diagnosis and maybe you have an idea of what medication you will be put on by your doctor, which is you. So then you can guide which plan that they might ultimately be choosing, because that coverage differs widely from one plan to another.
I don't know if they still do it. I feel like Walgreens used to do that, where they would say, if you get your prescriptions here, we'll look at your list and we'll try to help you find
I haven't heard
some
about
D
that.
plans.
Yeah.
I haven't seen the ads or the advertisement for that in a while, but I know, especially when D plans were new and everyone was confused about it,
Right.
they would look at your current med list and say, well, you could try one of these 4.
Yeah. I hope that idea comes around again if it was dropped, because then that will free up a lot of our time, because that's very time consuming to go through that with the patient.
I know, yeah, people will just come in and say, should I get SilverScript or Caremark? And you're like,
Yes, exactly. And then I used to get to tell all the people that sell the things or the drug reps, if you want to come into my office, you better bring the formulary for different plans. And then maybe I'll even consider taking your free samples, because you get those expensive samples in your office, and people, your patients get used to it. And then it turns out the plan they're on, they don't cover it. So I have like a stack or folder with all the formularies for different plans in my office sometimes. And then, yes, this is what we just talked about, like, you need to be knowing like what required prior authorization. You need to have like a PhD to go through all the formularies and look at all the like tier 1, tier 2, tier 3. There's the limitations on amounts, everything. All of that you can decipher there once you get through it. But of course, we're more aware of the medical terms than the patients. But for the patient, that's really, really important to find out. Some of them, right now, the popular things are meal order. For each plan, they have their meal order companies that they work with. There's eligibility for Part D, just more details. You have 7 months. You enroll between November and December. Right about this time, same time as what you enroll for the Medicare Advantage programs. Part C is Medicare Advantage. So we already talked about what HMO and PTO stands for. I haven't really seen the private fee-for-service part of the Medicare Advantage. It's almost like the idiosyncratic kind of way of doing things. Why not just go to fee-for-service and regular Medicare rather than putting that under Medicare Advantage program. So I'm going to skip through that because we have a lot to talk about in billing. Same thing. There's a little bit about COBRA. COBRA is for somebody who has employment, and then the employment coverage stops and they get covered by that. And there's a ton of Medicare policies here. There's a whole color spectrum of them. It's COBRA. We're going to skip that. We don't have time for it. So the only thing that I want to know is that if you can have both of them. If you have Medicare before you have COBRA, you can have both. But if otherwise, if you have COBRA and then you become eligible for Medicare when you turn 65, then the COBRA drops, of course. There you go. Medicare, I'm not going to go into that. It came out around the 90s. It's ABC all the way to M&M. Usually they have specific benefits for covering the travel expenses, like emergency coverage. They help pay for different things like hospital stays. They help you with the co-pays, and then they help pay for the blood, which seems to be pretty big. So hold on, let's go back there. So this is all the things that in a table format what they cover. There's for C to G, there's foreign travel emergency coverage, and then this is K and L. Most of them pay for the co-insurance and preventive services. The other thing that I wanted to talk about is, does Medicare pay for annual physical exam? What is annual physical exam?
Well visit.
Oh,
Yeah.
Medicare wellness.
It's not really an exam, is it? It's a checkbox of
Yeah.
seat belts,
There's a trick to it.
Yeah.
knife use, and guns and all.
First aid kit.
Uh-huh.
Lab work.
Uh-huh. So what do you think when you think about physical exam? What does the patient expect when you say annual physical?
They expect labs.
Do they want head-to-toe exam?
Yes.
Yes. Medicare doesn't pay for that.
For what?
Head-to-toe exam.
And the lab?
The labs, they don't pay for that either. You have to still pay as part of the treatment, but no preventive help. I'm going to go more into that detail later on. So, okay, remember that. So Medicare, I'm not going to waste my time doing that because there's a whole lot of them. I've never seen people with Medicare because it's really, really expensive. So this 6 months starting with the effective date, as Denise was saying, this is with a narrow window. I don't know why they choose 6 months. I mean, it would be more fair to do the whole year because most people don't remember what to do, and 6 months fly by really quickly. And Medicare, more. I don't want that, don't want that. So, hold on. So, Medicare is not part of Medicare, so people don't know that for the most part. So, that's pretty much all I need to know about it. And for some Medicare insurance, they don't cover the Part D, where the big money is. Aha, now, Medicare billing. Now we can talk the more interesting part of it. So going back to the physical exam, there are different terms that they use. There's something called Welcome to Medicare IPPE exam, which is not an exam. We talk about preventive medicine. So in the handout, it goes through all the details on when they're eligible for it, how you do it. There are EMR with templates already set up on how to do it. You don't even need a physician to do it. That's what I'm trying to say. For the most part, you only need maybe 5 minutes of your time. The IPPE usually takes about 30 to 40 minutes. The RVUs, relative value units that most private physicians have to know, you can pay a lot of money for that. It can be anywhere from $170 to $250 for each patient that gets IPPE. It's a shame because you don't do any physical. You can do it. It's on your own dime. You can do it. Nobody's stopping you from doing it, but Medicare doesn't require you to do a physical during any of the wellness visits. What you do is talk about home safety, whether or not you have emergency kits, first aid kits, you have guns in your home, you have rugs, and things like that. That's what we talk about. And then they screen you for depression, colon cancer screening, and things like that. Labs are not covered. If you want to do EKG, it's not free. You still got to pay for it. You still have to pay copay for that. So, any questions so far?
So theoretically, these exams could be done by your MA or your nurse.
Yes, you
and
got
can
it.
still bill your big bucks and move on and deal with the other things that are important.
Yep. So if you have 3 or 4 MAs working for you, you can do one day, make it all IPPEs. You're going to probably earn $2,000, $3,000, $4,000 that day.
Don't have to work the rest of the month.
Now, can you do the IPE and a diagnosis-specific visit on the same day?
Yes.
Okay.
Glad you asked.
So then
We use a 25 modifier for that. So if somebody's sick and they come in for an IPPE, you can take it for an hour and then you add a modifier, and then you can still bill IPPE and a huge level 4 established care visit on the same day. And technically you can get paid anywhere from $300 to $400 that day for that patient.
MA do the thing.
Exactly.
If you get 4 diagnoses, then you're ready for level 4, and you just kick them into the exam room.
Exactly. You got it. I'm going to talk about all the billing tips and tricks down the road. Yeah. Well, now I'm going to go into the politics later on too. So what is a new patient? 10 minutes.
This is a two-part.
It's a 2-part thing. Yes.
You need to come back.
Yes.
For your
But
finale.
I will go through some of the parts that are the good things. New patient for Medicare, for as far as Medicare concerned, is somebody who's not seen a physician of the same specialty as you in your same group for the last 3 years. Established patient, if that clause doesn't apply, then it's an old patient of yours. And then the other thing is one physician from each group, from each specialty cannot bill Medicare recipient on the same calendar day, more than once. So that's a big thing. Aha, now this is an EM codes for all the visits that you're going to have. So new patient, it ranges from 99201 to 205. Follow-up patients, it's from this number, 211 to 215. And then there are different codes for observation, the same. So if you've been there only one day and you just get discharged within the first 24 hours. So let's say somebody come in at 3 a.m., you work him up for chest pains or whatnot, and then at 4 p.m. if everything is good, he wants to go home, get discharged, then you use this code. But if the observation, the stress test doesn't happen the first day, then you bill initial observation care, that's 3 levels. And on day 2 out of 3, then you use the follow-up code 224 to 226. And then on the day of the discharge, you use somewhere around here, these ones. So this is an initial hospital emission codes 221 to 223. On day 2 onward, you use these codes 31 to 33. So this is the same day discharge. Oh wait, to go back. This is the same day discharge for both observation and inpatient. So this is a discharge if you discharge the observation patient on observation after day 2. You use this 2217. There's only one for observation discharges. And then of course there's inpatient, outpatient consults, critical care services. I want to go into this because most people don't know about it. You have to be in the same area or readily accessible to your patient within that critical period of time. You don't have to be continuously be near the patient. As long as you don't go and see another patient, then you can count that as continuous. The first 30 to 74 minutes is $992.91. It could be anywhere from $180 to $200 reimbursement. For every additional 30 minutes, you add on to it. 99292 times n. N is the number of 30 milliseconds.
So this is one of those situations where something squirrely is going on and you have to sit by the room.
Or at least in the same floor and talking to somebody. You can walk away for a little bit,
Right.
but if you're still talking and taking care of the same patients, you can still code for that. And that includes talking to the families, getting story, family conferences, the whole 9 yards.
Cardiologist.
Right,
Yes.
the orders, the transfer of the unit.
Exactly. And we're looking up his records, everything counts.
So the intensivist on the floor who's just gonna stay there,
Oh,
keep
yeah.
on billing.
Right.
Yeah.
Exactly. And then nursing care notes, essentially the same. So this is a IBP that we're talking about. There's a code for that. If you want to know what is the code. And you're eligible within the 12 months of having active Part B. And then if you miss that, but you still have Medicare, but you haven't shown up to the doctor's office, you use the annual WellMed visit. It's the first one. And then for the subsequent ones, you get paid this much. So from $200 to $300, down to $100. And the chronic care management is a new code that I found that is brand new. So what it is once there's stipulations for that. If somebody has 2 or more chronic illnesses like hypertension and diabetes, and you take care of them, and you're readily accessible for that, and the patient sign a consent that you want to be under that care, then it's just almost like a HMO plan, but any private doctors can enroll the patient in there. And for each patient that is eligible for CCM, you have to pay $42. So if you have 3,000 patients and you have 600-700 of them under the CCM, then you get paid like $250,000 a year.
But you're not
Just doing that.
able to bill for those diagnoses if they're enrolled in that. You just automatically
No.
get paid $42.
On
So
top
they-
of the fee for service
Oh,
business.
so I enroll them in that for their
Yes.
COPD and their diabetes.
Yes.
And then every time they come in, I can also bill for those diagnoses.
Yes.
So this is their way of trying to reimburse the physician for like when the patient calls because their blood pressure is 180/90.
Yes.
And you talk with them, adjust the medication,
Mhm.
and then say,
There's
call
a-
me next week and let me know how your blood pressure is
There's a
doing.
stipulation. Good that you mentioned 30 minutes of on the phone or any other electronic media time. You have to document that. There are computer companies, software companies that are advertising that like crazy, that will help you meet the Medicare criteria so that you get paid for that.
I'm staying in the Air Force.
Mhm.
And then there's a telehealth. So if you have remote data collection and interpretation in connection with this, you can add those two, and then instead of $40, you get $100 a month per patient. That's how much.
Can I ask-
Yes.
So when you're in private practice, who
Mhm.
helps you manage all this? Did you have like a manager? Or did you do it all?
We have classes. We have
You
coding
just get
classes.
Ah, okay.
You get coding classes, you got to be really good at it. We get refreshers every 6 months or every year. And then they see your performance. If you're not doing it well, then they will go make you go back to the class again and again.
So you get it right.
Till you get it
But no
right.
one's there like maybe helping, assisting.
There's a billing people.
But they're somewhere.
The billers that are either, if it is under the same building as you, you're lucky, or you can call them, is there a phone call away? You can ask all of these questions. But the office manager or the practice manager who knows finances and accounting have to help you with that. But they are the one that's always follow up on all the policy changes, coding changes, requirement changes. Now, to do the CCM, you gotta be EMR certified. There are different level of EMR certifications you have to know. If your practice is not EMR certified, you cannot charge for that. Because then the stipulation is you need to be accessible to the patient 24/7, almost like concierge medicine. So now you understand the billing part, we can skip after we go through that a little bit. One thing I want to show is towards the back, maybe we can visit that at another time for people who are interested. You can sign up for that. I can talk about that. But you can know, it's just you can get the idea that it gets very complicated. You need a lot of people to, and that's why Medicare is very expensive. So like there are three components if you want to bill and code properly: the history, exam, and medical decision making. You need for 2 out of 3 key components for established or follow-up patients, but you need 3 out of 3 of those key components if you want to see new patient consults or admissions in the hospital. This is a history part, broken down into chief complaint, HPI, ROS, and past medical, family, and social history. Level of history taking. If you have a chief complaint, you need it for everything. Brief HPI is almost nothing. If you have a ROS, then that's fine, but this is the key part. If you want to code level 4 and 5, as long as there's 3 chronic medical problems, you can skip all of that. You can have the chief complaint, but you don't need to have a detailed HPI, and you can have some ROS and the 3 components of the history, which will be past medical surgical history, smoking or not, smoking, and just any other part, whether they're married or not. So, examination. If you are going for a multi-body system, you need 2 bullet points in each selected 2 9 body parts. Then there's a detailed body system for people who are specialists, cardiologists. This is a good part that I want you to take away. It's very easy to get all the 9 systems. There are some of the things that you don't have to have people disrobe at all. You can get constitutional exam point just by general appearance, how they walk, vital signs. How they walk, you can just get from the gait. You look at the fingers, if they have deformities, things like that. You get 2 points in here. 2 points here, psychiatrist assessment. All you have to do is talk to them for a few minutes and you know whether they have insight or judgment or assess their mood. Skin, if they have rash, if they have nodules, if they don't have it, covered. Look at the nose, ears, external ears, mouth and gum, that will be covered easily. Neck, more or less, you can cover that. The rest, everybody listen to the lungs and the heart, very easy to cover. Abdomen, make sure you inspect for mass, tenderness, and hernias, and that completes it all. So it's very easy to get the 9 points. So always remember this 9 system, and you always code level 5 all the time. You don't have to even worry about any of that. You don't have to look at the genitals, breasts, or any other parts. Fundoscopic eye exam takes too long. It's not pertinent unless you really suspect something. Touch leg exam is last time mentioned. General exam, ENT, eyes, and all of that. You can just look at people and you don't even have to touch them. Medical decision making, the takeaway point for that is if you have a new diagnosis, that diagnosis level, if you have a new problem that you're going to work up, that's automatically 4 points. So if somebody's in the hospital or a new consult, automatically 4 points. Data complexity, if you decide to get old records and we review and summarize in your HPI their history, and actually these are not right. These are going to be 4 points and all that. Then you already got those points. So for example, this is an easy level. So review and summarize, decide to get more records at 3 points. And all you have to do is comment on the lab and you sign that lab and then you automatically get 4 points for the data review. With that alone, you don't have to do prescription and you meet the criteria for that. Okay? So it's getting late. This is the gist on what we are dealing with, but If you want to hang around after we do this, I can continue talking about that. But if you have any questions or comments, Denise?
I just want to let if you're interested in coding and you're planning on going into community practice, the AGS meeting always has good sessions on expert coding, and I've learned a lot by going to those. Al's brought a lot to us today. So when you go to AGS in May, look for those in the schedule because they're always really good sessions.
Good.
Thanks a lot, Al.
Thank you.
All right, be sure to sign in so you can evaluate on today. And check your stand box.
Yeah, how are you doing? I'm not sure, I may be persona not there, but I have my questions. I worked them for 5 years. I know pretty much, you know, what's the account. So I'm gonna
Oh, yeah, we'll
reach
check
out to
it out.
anybody now.
For